It's easier for me and probably better for you if I do it in English, although I understand the Spanish reasonably well. So I was given an enormously long and perhaps slightly complicated title, and it's probably hard to do completely justice on the enormous amount of work that has been done in this area, but I'll do my best. Over the years, I've had conflicts of interest with all the companies that make proton pump inhibitors and GlaxoSmithKline, but none of it, what I'm going to tell you today, is relevant to my talks. So I'm actually going to spend a lot of time on treatment because I think most of the controversies and changes have been taking place in that particular area. So I'm going to focus on treatment, and I'm going to especially address the question whether there's more or less a global consensus on this issue. But I will say a few words on the importance of the histology, what type of gastritis is present in the stomach, and say a little bit, once again, about treatment of functional dyspepsia. So the last couple of years, there's been several very well done systematic reviews and meta-analysis published. I myself was involved in the Canadian treatment guidelines, and as the consensus is pretty much centering on what was said in this consensus conference, I'll use that as a yardstick. I can tell you that the Spanish guidelines are virtually the same, and the similarities between the guidelines across the world are getting closer and closer. So, okay. Right, thank you. So I love this particular slide because it does show that Helicobacter actually is an offshore organism. It lives deep in the gastric mucus, yet is able to induce a profound immune response with consequences of ulcers and cancers among the most important ones. Yet it is interesting that actually we have many unknowns when it comes to treatment. Yeah. So we've basically played Russian roulette, tried different combinations of antibiotics, and went with the winners. But in fact, for most antibiotics, we're still unclear how Helicobacter is destroyed. For many antibiotics, we don't know the right dose. We don't know the optimal duration of treatment, although we're centering more and more on 14 days. And then, in many instances, we also don't completely know why treatments fail, although resistance to antibiotics clearly is one of the most important things. And here, on the next slide, I show you the chemistry of the structural chemistry of these, the antibiotics that we use the most, metronidazole, amoxicillin, and clarithromycin. And you can see they're very, very different. So how the stomach actually handles those antibiotics, for the most part, is unclear. We know for sure that metronidazole and clarithromycin can easily transverse the gastric mucosa when it comes from the systemic circulation. For ampicillin and amoxicillin, this is unclear. Now let's focus on the treatment. So one of the most important things, and it needs to be reiterated, is that if you want to have success with treatment, you know how effective your therapies are in the location where you practice. So if you treat, you have to follow a substantial number of patients to get some idea what your success rate is. And for this, there is no question that data on antibiotic resistance are crucial. But the fact of the matter is, in many places around the world, including the country where I practice, which is Canada, for many places, we don't know what the success rate of therapy is. Now, we're going to talk about the treatment, and I'll quickly label them. So classic triple therapy is basically a combination of a PPI with clarithromycin and amoxicillin, clarithromycin and metronidazole, or amoxicillin and metronidazole. There is good evidence that 10 days is better than 7 days, and there probably also is reasonable evidence that 14 days is better than 10 days. But there is a problem with these triple therapies, and this is an often quoted publication from Dr. Graham. And what you can see is this is the number of randomized trials here listed by year of publication, and what you can see is over the years, the success rate of the therapy has gone down quite dramatically. And for example, in Canada, the success rate used to be 80–85%. It is now down to about 60%. So for that reason, although the situation is different in Latin and Central America, in many places around the world, triple therapy is no longer recommended with the standard treatments. This is bismuth-based quadruple therapy. I think in many places in Latin and Central America, you have colloidal bismuth subcitrate. In North America, we have bismuth subsalicylate, Pepto-Bismol. So it's a combination of a PPI, bismuth, metronidazole. I am a firm believer that the higher doses of metronidazole are better. And in fact, I use 500 milligrams 4 times a day. And then the fourth one is tetracycline, which is good, but it increases the side effect profile of this therapy. And the other issue is that this is 20 to 24 tablets a day. It's a very complex regimen. Patients often don't like it. So the next one is sequential therapy, where you give the PPI and amoxicillin for 5 or 7 days, followed then by clarithromycin and metronidazole. And the thinking is, and there is some evidence, by using amoxicillin first, you markedly decrease the number of organisms in the stomach, and then you subsequently come on board with clarithromycin and metronidazole to finish the job. So this is sequential therapy. But it's now sort of been overtaken by what we call concomitant therapy. I tend to refer it as CLAMET, clarithromycin, amoxicillin, and metronidazole. So you give all drugs for 14 days, and it's basically giving more drugs when you compare it to the sequential therapy. And then the last one I'll mention is levofloxacin-based therapy, which is a combination of PPI, amoxicillin, and levofloxacin. And again, I tend to use the higher doses, but most of the consensus recommendations use the dose of 250 milligrams twice a day, okay? So here I'll make a couple of statements as they appear in the different consensus guidelines. So the duration of H. pylori infection, for the most part, should be 14 days. I still think many of you probably treat 10 to 14 days, but I make a plea that you go to 14 days. There is really good consensus that the longer durations for all therapy, your success rate is higher. And on the bottom of the slides, I'll list a little bit of the differences between the different consensus guidelines. So the American guidelines and the Maastricht guidelines from Europe list 10 to 14 days for concomitant and bismuth. We in Canada and the Spanish group said the same thing. Also for ease of understanding for primary care physicians that treat many of these patients, we recommend 14 days, okay? Now what about the preferred first-line therapies? So the first important point is, but I'll come back to the situation in your countries, is not to use the classic triple therapy anymore. It's out. It's certainly out in Canada. Now there is evidence that if you know that in the area where you practice, your resistance rate is low for clarithromycin, less than 15 to 20%, you can still use it. But in many parts of the world, this no longer is the case. And Maastricht, the Canadian guidelines and the American guidelines all agreed on this particular point. So we don't use triple therapy anymore. So the preferred first line is climate or concomitant therapy, given for 14 days, all the drugs. Once again, in Canada and in Spain, we recommended 14 days for ease of all the treatments. The ACG guidelines say 10 to 14, and Maastricht says only use 10 days if you know that it works. Okay? Now, we use concomitant because it's the easiest to take for patients. It is easier than bismuth-based quadruple therapy. Now, bismuth-based quadruple therapy has stood the test of time. It's been around for a long time. It works, but it's complex. Again, in Canada, we said 14 days. There is some disagreement about that because it's true when you do systematic reviews, there is no clear-cut evidence that 14 days is better than 10 days, but the number of studies isn't actually all that high. Now, one of the reasons that bismuth-based quadruple therapy is good is that it deals in part with metronidazole resistance. When it comes to clarithromycin, when it comes to levofloxacin, resistance is an all or none phenomenon. So if you're resistant, there's no point leaving the medication in the regimen. This is different from metronidazole. Metronidazole can be partially overcome when you leave it in the regimen. But as you can see here in the lower part of the slides, the success rate of bismuth-based quadruple therapy is higher if you know the strain is sensitive, it's 92%, whereas if resistance, it's about 80%. So metronidazole resistance can be partially overcome, and this is one of the other reasons why I prefer to use the high dose of metronidazole, which is 2 grams a day. Yeah? Now, the Canadian and the Spanish guidelines have gone further than, for example, the American guidelines. So we recommend against the use of levofloxacin as first line. And the reason is that the background resistance of levofloxacin, and I'll show you some data for Latin America as well, is actually already quite high related to the use of levofloxacin for other indications. And once again, if you're resistant to levofloxacin, there is no point leaving it in. The Americans say, no, you can use it as a first-line therapy, but I personally don't think it's a good idea. And here you see the dramatic effect that levofloxacin resistance have. So if you're sensitive, very high success rate. If you're resistant, it drops dramatically. Now, I mentioned sequential therapy. And so, although it does work, I used to use it a lot. It certainly worked in the area where I work. But both the Maastricht, Spain, and the Canadian guideline says don't use it first line. The American guideline says no, you might. Now, why do we prefer concomitant, so giving all 3 antibiotics for 14 days, over sequential therapy? Basically, because it's better. So here you see it's already a little bit outdated, but the comparison between sequential therapy and the concomitant, the climate 14-day therapy, and basically the evidence is quite clear that concomitant is a little bit better. And why is it better? You can see here that, so once again, clarithromycin resistance is less effective. So the other 2 antibiotics given 14 days overcome this resistance. Resistance to metronidazole is better overcome, and in particular, although dual resistance isn't that high across the world against metronidazole and clarithromycin, concomitant is significantly better. So if you go from sequential to concomitant, the prediction is that in your area it will be 5 to 10% better than sequential therapy. Now, what about the situation in Latin America? And this is actually very interesting. So this is a very large, impressive study done, published about 5 years ago. It involved 6 countries. 2 of the centers were in Mexico, large numbers of patients. So, but it's an interesting study, but it's also a little bit of a surprising study because one of the main drivers of success of therapy is duration. Now, this was based on the literature, how long you give. But so you use different antibiotics, but you also use different duration. But what it importantly shows, apparently in Latin America, So triple therapy still is pretty good, although my prediction would be that concomitant is going to be better, but the most important thing is that you find out in the area where you're working. So it was borderline statistically significant in the 10 days sequential, and it certainly was better than the 5 days concomitant, although nobody gives 5 days concomitant nowadays. But in your countries, triple therapy still seems to work. Now, what about resistance? And again, impressive amount of studies done, published a few years ago in the Red Journal. So this is based on a large number of studies and really large numbers of strains. So amoxicillin resistance, as across the world, is very rare. But based on these studies, your clarithromycin resistance was low. You know, this was based on 35 studies, 6 came from Mexico. And dual resistance to clarithromycin and metronidazole was also low. But I want to point out, although here the number of studies is low, resistance to levofloxacin, you know, background resistance, is 15%. So again, this would reiterate the recommendation made by some of the consensus guidelines not to use levofloxacin as first line. So there has been an updated Latin American consensus conducted as well a couple of years ago, and it did, based on the data, recommend that the triple therapy can be used, but it really said you should go for 14 days, and I believe that is right. And it listed that sequential or concomitant therapies could be considered as an alternative. Okay. So, and again, similar to the Canadians, Maastricht and the Spanish guidelines, yeah. Don't use levofloxacin as first line, but you can use it as a second line or third line, depending on your preference, whether you prefer bismuth-based quadruple as second line or this as first line. And second and concomitant are perhaps alternatives, okay? Now, when it comes to second line, it's a bit of a toss-up. Both work. The levofloxacin therapy is easier to take for patients. There's way more data on bismuth-based quadruple therapy. Yeah? Now, the Canadian guidelines and the Spanish guidelines went also a little bit further. This was statement number 10, that stated that if you've used a clarithromycin first line, the patient failed, don't use clarithromycin. And the same is, if you've used a levofloxacin in your therapy, don't use it as second line, yeah? Now, so you use either concomitant first, levofloxacin or bismuth second and third, and then the fourth line therapy, but this usually should be done for sure by gastroenterologists especially interested. We use rifabutin, which is the only therapy that is given for 10 days. What to do in patients with penicillin allergies? The evidence, although there's not many trials, bismuth-based quadruple therapy is better than the triple therapy with clarithromycin and metronidazole, higher success rates. So I use bismuth-based quadruple for the first-line therapy. Finally, what about probiotics? They're very popular with patients. The Canadian guidelines and the Spanish guidelines were really very strong on this. So in Canada, we say don't use it. Don't use it to decrease side effects. Don't think you're going to increase efficacy of treatments. It generally doesn't work. And the reason is probiotics vary enormously in the products, how they made, and so on. And the studies to date are actually quite long, quite weak. Now then a little bit, as I said, close to finishing, about what about the state of the inflammation in the stomach. Here you see severe atrophic gastritis in a patient who was Helicobacter pylori positive, which sometimes, but not frequently, can lead to, in this case, an early gastric cancer, and intestinal metaplasia is an important risk factor. So apart from focusing on Helicobacter, I'm going to show you data from one study, but there's data from the Netherlands as well. So this is a large Swedish study where they had access to reports of histology. So these are people who had more than one endoscopy over time, and they looked at the cumulative incidence, the risk of developing gastric cancer among patients. And they looked at the baseline diagnosis. So what you see here was normal, minor changes. Here you see gastritis, atrophic gastritis, and then intestinal metaplasia, and here metaplasia, where the risk over time, as you can see, of developing gastric cancer goes up. And it was very interesting. What they showed is if you repeat the gastroscopy, if there was progression rather than that the abnormalities were stable, that your risk went up. But just, this is a little bit of a sobering statistic. If you do, let's say in a 55-year-old, a endoscopy, and you find intestinal metaplasia, the risk that that person will develop gastric cancer over time is 1 in 39, which if I knew my chance was 1 in 39, I probably 5 or 10 years later would want to have a repeat gastroscopy. So both Maastricht and Kyoto, which focused a lot on the consequences of gastritis, do state that if you have more extensive and severe atrophy and intestinal metaplasia, usually meaning that it involves both the antrum and the body, that you should consider offering these patients follow-up endoscopy. And I tend, if it's severe, tell patients to come back in 5 years. So in closing, I believe you should use 14-day concomitant as first line, but I acknowledge that in Latin and Central America, the data still support the use of the classic triple therapy, but go for 14 days is what I make a plea. The data for second line are more robust and more extensive for bismuth-based quadruple therapy. I increase the dose of metronidazole to 2 grams a day. Amoxicillin, levofloxacin is a good second or third dose. It's easier to take for patients. And then fourth line, rifabutin. And if you follow this sequence, your success rate of treating Helicobacter in most places will be 97 to 98%. Yeah? Treatment should be given for 14 days, and I think here also, if you use triple therapy, use 14 days. In Mexico, it certainly appears to be a good option, and it'd be interesting to hear in the discussion what you believe about concomitant. And then finally, that the 14-day bismuth therapy, you can use it as first line, use it in penicillin allergic patients. I tend to use it as second or third line. Thank you.